This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, this is going to be the fourth installment of the trauma series on spinal trauma with Jim Walmsley. So in the conversation, we're going to examine some of the recent changes in spinal immobilisation within pre-hospital care. So we're going to look at the historical literature, we're going to look at the prevalence of spinal injury, we're going to also look at some of the recommendations from the Royal College of Surgeons and the NICE guidelines. We're also going to look at some of the current practice we see on the ground with C-spine collars and indeed extrication advice. So to do this, I have Jim Walmsley with me. Jim is a critical care paramedic at South East Coast Ambulance Service. He is also a flight paramedic at Hampshire and the Isle of Wight Air Ambulance Service. So he has a 19-year history with the ambulance service and also done a lot of varied work in clinical practice, research, undergraduate teaching, as well as managerial duties. So he is also a World Extreme Medicine faculty member and has taken on board multiple expeditions abroad. He's also no stranger to the podcast. Welcome, Jim, to the podcast.
Thank you so much. It's wonderful to be back again. And yeah, it's great to revisit where we last picked up, actually. So yeah, thank you for the invite.
Oh, it's great to have you with us. Jim, I just wondered, there has been a lot of evolution within spinal trauma. And I guess if I could just maybe get you to speak to maybe more of a scene setting question and just if we could just revisit some of the common causes that the everyday paramedic or indeed EMS personnel see on the ground in pre-hospital care. And indeed some of the patterns of injury you see and how these might have evolved over time.
Yeah, so I don't think probably too much has changed, actually. Historically, and still we see a lot from what we would call road traffic collisions, or RTCs, or motor traffic collisions. Falls are a big issue, and they create a lot of spinal cord injury. Violence, obviously, where there is extreme violence and people who are subject to that. Sporting injuries, and I wonder if that's maybe where some of the increase is. We see wonderful videos on Instagram and these amazing sports that normally are defying gravity, but at some point, sometimes gravity wins. But also we can't ignore or sort of forget pathological disease, and you know, while it's not omnipresent or stuff that people are motivated by with regard to clinical care, certainly within my ambulance service role, we see more medical patients, and therefore they fit in as well. But by far, the ones that stick in your mind would be the RTCs and the falls, really.
So just looking at a few, or just the red flags, the main red flags that you would want to have front of mind, Jim, either, like I said, on a flying shift or indeed as a ground-based critical care paramedic. So if you were to turn up to scene, what are some of the common symptomatology or indeed red flags that you would want to discount or disclude when looking at spinal trauma?
For me, I think it falls into two camps, and I think if we can stick on those two sort of principles, you can't forget too much. The first is is it a high-end mechanism? Has there been some kind of high energy? As we know, energy has to be absorbed, and or a person, a patient, an individual will absorb that energy. So what is that mechanism? And often that is really obvious. Sometimes you have to dig a bit deeper. Sometimes you have to remind yourself and take a step back. So a patient, an individual might present with, I don't know, a slow heart rate, but actually you're thinking about dealing with that. You have to take a step back and really realize what is the mechanism and try and work that out. Where have they been hit on their body? And then the second part, that second principle, is a exquisite primary survey. We talk about primary survey being king, often not done well. And if you give your space to do that, that does really elicit a lot of information. It gives you a real basis of what the problem or problems are. And when done well, and you can do a modified primary survey, for example, if they're conscious and talking, maybe they're trapped in a vehicle, you're not able to get your hands on properly and your eyes. Getting that primary information is really key. I suppose to tag on to that, then being able to, if you can, do a secondary survey and understand a bit more about what kind of altered neurology there is going on. It might be they're saying they would like to basically have a pee, relieve themselves of urine. In trauma, that you have to take as a concern in the context of trauma. Have they ruptured their bladder? Have they ruptured some vessels or some abdominal concern? So I would say the two things are mechanism, question mark, what is? Primary survey, do exquisitely. The rest works really well to then really dovetail you into a bit more of a nuanced diagnosis differential of what's going on.
So we've covered a number of episodes on the podcast recently about the changes in practice. We looked at the exit project or exit trial with Tim not being recently around just some of the ghost literature and also some of the lack of research which has fallen forwards into paramedic practice and still informs care today. And I guess my question on the back of that, Jim, is could you maybe speak to whether you're seeing traditional methods like backboards or indeed collars even used across emergency care or indeed paramedic practice? Are you seeing the evolution of care and just the moving beyond collars? Is that a daily reality for you now?
It absolutely is. My practice, where I practice in the UK, I'm very lucky. I consider myself to work in some of sort of the industry leading areas pre-hospitally, and we are not seeing collars. The only place that collars have a place are with exsanguinating maxillofacial injuries, where we would use them as part of a construct to reconstruct essentially the front of a skull to give patency and structure for an airway. That's the reality of my practice and has been for a good number of years. Even abroad, I've just come back from running a course with World Extreme Medicine in Chamonix, and we've spent some time with PGHM, who arguably are one of the world-leading air medical rescue services, and they do a range of approaches where actually, they will extract where there is a risk or a concern for a more primary requirement, or it might be an environment. They do obviously immobilize where indicated, but what I'm seeing more and more on my reflection of where I work here in the UK and across the UK is a move more to a spinal restriction rather than a spinal immobilization. And it makes sense to me. We last spoke about back in the day, even 20 years ago when I started, rapid takedowns using longboards, collars getting absolutely pinned onto every single individual, whether it fitted, it was a good fit, whether it was well measured, whether they required one or not, and then assuming that a collar or a longboard was just your immobilisation. It's been really nice to see that evolve in practice to be more patient-centric, and we do have to be careful. I often hear there's very little evidence for pre-hospital assessment of spinal cord injury or immobilisation. In fact, there's quite a lot. The problem is that it's just not level 1 RCT, double-blinded, systematic method, or there are systematic reviews out there actually, but not a meta-analysis maybe, and or not too many. And we have to be careful. I think words are important. And I would suggest that there is evidence base, and actually in lieu of no evidence prior to what is available now, we do have quite a good bank of evidence, including Delphi-style studies, systematic reviews, things like the EXIT projects that are really trying to earnestly guide us outside in the pre-hospital environment to improve guideline and protocol. So we don't see the longboards. They're only for extrication, which is great. And then they're taken off those. Predominantly, we're seeing orthopedic scoop stretchers, these yellow Furno stretchers where patients can lay on those patients for longer. Patients can lay on the scoop for longer, up to an hour. We're seeing modified immobilisation restriction. For example, elderly, frail, so-called silver trauma, where they may have gross skycophis or scoliosis. And we've got to really be patient-centric. And this, I'm sure we'll come to it again, but there is no one-size-fits-all.
So let's go there actually, and let's talk about the guidelines, Jim, because there has been evolution, and there's a real meld at the moment. I wondered if you could just speak to fundamentally whether the Canadian C-spine rules or indeed the NEXUS criteria still stand, but also just the Faculty of Postoperative Care's latest guidelines, just and how maybe the EXIT project has informed that, and what the latest guidelines really teach.
Yeah, of course. I think everyone wants a silver bullet, right? Everyone wants a panacea. Everyone wants do this, and that equals 1,000% success. And we always clamber for that. We're all desperate for that, and particularly maybe services or resources that aren't medically registered roles or advanced roles or enhanced care roles. What I would say is that whether you're using Canadian C-spine or NEXUS, they really do give us a sensitive scaffold to find objective information, to really pin down what is in front of us. And it gives us a structure, it gives us a scaffold. Both systems are sensitive. However, they do sort of lose some specificity, but that's okay, because we say that we are going to assume, we will assume a spinal cord injury until otherwise proven. And what we're looking to do is really nuance how we manage that patient. So is that individual suitable and appropriate for self-extrication guidance, minimal handling, minimal movement? Or do we need to be a advocate for better care and move to a lower risk, full restriction and then immobilisation? And while the Canadian C-spine looks at or asks 3 questions, what is the risk? Is it high risk? Are there any low risk factors? And then can the patient essentially move their head and neck without symptoms? once you've answered the first two questions. With NEXUS, it's more around symptoms. It's around whether they're intoxicated, what's their conscious state, is there altered neurology, but they both have good sensitivity. And maybe the Canadian C-spine rule trumps a little bit, but where I work in one of my organizations, use combination of both, and that we find works well. And I'd be wrong to say how many years, but it feels like 5, 6, maybe 5 years, 6 years. So we're doing well. With regard to the Faculty of Pre-Hospital Care, they have released latest guidelines. They're very easy to find. And essentially, in summary, what they state are things like, what is the risk? Is it high? Is it low? Cut your cloth accordingly. Are they frail or elderly? Is this a silver trauma situation? Lower your bar, increase your threshold for risk. A real emphasis on restriction over immobilisation. However, if we are going to immobilise, look for full immobilisation from the top of the head all the way through using scoop, blocks, tape. And there is also discussion around pelvic binder, which really, that is going to be an interesting topic to watch in the coming months, years, because there's a lot of talk in the bazaars around, is the pelvic binder the new sort of neck collar, and is actually, does it bring benefit? Is it causing harm? And does it make a difference? But the emphasis is high or low risk. Are they silver trauma? Emphasis on restriction or immobilisation, including the pelvis. Self-extrication if appropriate. You're going to have to use a system, something like Canadian C-spine or NEXUS. And remember, these were research tools that were designed to try and find a sensitivity point around whether the hospital should carry out a X-ray or a CT scan or a more complicated scan.
Listen, I think that's a really good point, Jim, you make. And one of the things is around, you just said, it was a hospital. So the NEXUS National Emergency X-ray Utilization Study is fundamentally an in-hospital study which looks at symptomatology. But to your earlier point, and I really like that you said this, what the Canadian C-spine rules capture is this mechanism of injury, and it's a semblance of energy transfer. And, what was the energy transfer? And again, and I think this is why it's difficult to pin down. And we'll put the Faculty of Pre-Hospital Care guidelines in, because it is risk stratification. You absolutely, because no two injury patterns are the same. No two RTC, road traffic collisions, are the same. So it has to be a stratified approach. And there can't be, like you say, I think we all crave linear cutoffs, and we all crave directive protocols, but actually we're in such a nuanced field of, and indeed a variety of injury patterns and injury loads. You have to have, like you said, a stratification tool to capture the mechanism, because it varies from patient to patient. Could I get you to speak to over immobilization and the risks? We've spoken about this before, but I think it's sometimes worth both stressing and re-stressing. The risk benefit and fundamentally the risks of collars, the venous drainage or preclusion of venous drainage, that it doesn't stop you lateralizing your neck. And could I get you to speak to some of these risks of over immobilization?
Yeah, absolutely. And I think it's a really fair and valid point to make. I think to do a full immobilization is easy, and in some ways to do that, I work alone when I work in the ambulance service on a car. I often back up crews, and let's say we've gone to a road traffic collision. I might say to that crew, look, listen, let's fully immobilize this individual, because it's easy to do. It's easy to do correctly. We have some great equipment. So we use vacuum mattresses, which really contour whatever body habitus we might have in front of us. We use blocks and tape along with the scoop. They lay on a scoop. And sometimes that translates to an easy journey for patients with hospitals that are very protocolized, that have a culture of essentially sending the balloon up for help and asking for all the specialities to come down as a trauma call, when maybe a lot of these patients don't need that. So I think it is an easy thing to do, and an easy thing to do well. It's also an easy thing to do not very well and cut corners. Having said that, sometimes I can think of two young teenagers that had ridden an electric scooter at fairly high speed in front of a moving car that was traveling maybe 40, 50 miles an hour. They were projected through into the windscreen of the car, and then splayed out sort of several meters either side of this car coming to a sudden halt. Very dramatic, very chaotic, a lot of bystanders, family. It was short of pandemonium going on scene. Very distressed, very emotive young adults involved. And essentially, we went about a job and we did a full assessment, made sure that we could prioritize what needed to be prioritized. But essentially, these were patients that had a high risk and a risk of injury. However, on primary survey and then secondary survey was reduced on clinical assessment. But we took no chances, particularly with one. But we altered how we immobilized, and we went for a restriction. So rather than do a full immobilization, lots of confounders, we had people interrupting or family, there was lots of chaos. Let's do mobile inline mobilization. Let's get into the back of our ambulance. Then we can do our secondary survey. The other young person adamantly would not engage with us, didn't want to receive care or intervention. And so we went for a reduction of risk, a reduction in restriction of movement. But that equated to, listen, can you please lay down on this scoop? We'll put the scoop onto the stretcher into the ambulance. Two different patients, two different crews, and let's reassess them separately once everything's died down. So that's one example, one thought that I have. Another job, essentially cyclist, no helmet, middle of a country road, middle of the dark, night, no lighting, collided by a car from the rear. And that car going at speeds. Essentially, that individual had on primary survey a very nasty isolated head traumatic brain injury with a number of confounding problems like periorbital hematomas, a difficult airway to manage, reduced GCS, but also was presenting as what we would call a code red, so a concern for true hypovolemia and internal injury. But in fact, actually, we managed accordingly. We did things that we needed to do, which was to provide a safe anaesthetic, provide blood products, thinking maybe we have a code red situation as well as immobilise, as well as look after this patient. But actually, there were a number of other problems that needed to be addressed. First, so when we arrived, we had a soiled airway that needed managing. My point about that is that actually, thinking about the mechanism, it was clear to us that we've got a probable spinal cord injury, and we've definitely got a head injury. But do we also have other injury, chest, abdomen, pelvis? And I think the key there is that you're going to be looking to have individuals and a team or teams to do multifaceted work, to work in combination at the same time. And while we all are desperate for a B, C, D, etc., a linear process, a linear protocol, do X, if we have Y, we do Z. I really do believe in a professional system that we are multitasking, and certainly you can go on courses that really emphasize that. So, for example, the European Trauma course has a real emphasis on team approach rather than an advanced life support course, which is a fantastic course, but that's very much an individual working through a process, working through each system, not moving on until they've maximized management of that. And I think those are sort of cases that would come to mind where it might not be immediately obvious. You might have competing interests. It might be that you have to modify what you're doing because it's not an ideal situation, and you just have to manage the situation with a bit of nous, with a bit of street thinking, and just going, right, let's get to where we need to. You know, the two young people on the electric scooter, the second individual was really difficult, and there was a crew that was trying to pin them down. And I'm like, look, that's not going to work. Let's just stop. Let's work with this individual, but we'll have those principles to mind and see what we can deliver.
So, Jim, kind of answers one of my questions. I was going to ask you about multiple patient situations, actually, because they are tricky, especially with non-compliance, and actually how non-compliance can actually lead to a proliferation or indeed worse injuries, actually, when they're starting to fight, patients are starting to fight. And to your point around winning the patient over so that you can initiate the treatment, but that's a psychological battle before it's a physical one in someone who is either combative or indeed just isn't compliant.
Yeah.
Could I get you to speak to, you've mentioned a couple of things. One was around increasing the threshold for immobilization for elderly patients, for geriatric patients, and indeed the pediatric patients and geriatric patients are two of the most challenging patient groups, I think, because the profile changes, but also, especially with children, there's an occult sense of a hidden sense of injury load. It's not always abundantly apparent, and a very difficult population to manage because, again, you're not the primary caregiver. Therefore, there is often a primary caregiver there who is the second patient because they're either psychologically or physically injured as well. Could I get you to speak to your approach to pediatrics and how you potentially work through the family, and indeed how you either immobilize or provide care vicariously through the patient?
Yeah, they're a tricky pickle, you know. Often it's not actually the patient, it's not the pediatric individual that is your contender problem number one, and they either, you know, those around either work really well with you or it is really challenging, and that's out of concern, worry. They maybe exaggerate the risk in their mind because they're ignorant and ignorant to what's going on, and they're worried. In the first category, I can think of a young 14-year-old boy that came off his scooter without a helmet. Essentially, it was very clear that he had a obvious closed tibial fracture, had somehow managed to hobble to the side of the road. He got picked up by the car that hit him, took him back to his house. Essentially, on arrival, he was a really charming individual, and he was brilliant. And I think the first thing is to just approach, change your approach, change your language, change how you enter into that frame. And that is, you know, along the lines of, hey, buddy, you're in charge. Whatever you want, we can do. Do you mind if I just ask you some questions? While maybe if you have to, someone else taking parents aside and getting them on board. In this case, I didn't need to, but I checked in with the parents and just made sure that they were on board. They absolutely were. And it was a dream, but it was about pitching myself to a 14-year-old level. They are scared. They're wondering what's going on. if you take all of those things away, it's really fantastic how much you can achieve and what you can do. And we were able to give exquisite care for that young individual. So that works well. On a different scenario, I've spoken about this before, you might have a baby that's been hit by a car from behind, thrown up into the air, landed on their head, is a reduced consciousness. Maybe they're showing signs of fitting as well, or agitation. You're going to do the best that you can until you can get the right care or enhanced care. And in that situation, or maybe let's say it's a different kind of a trauma with an older, younger adult who's still classed as a pediatric patient, you might have to say, so for example, with the latter patient, you might have to, they might be on an ambulance when you arrived, you're in a built up urban area, there are houses everywhere, people hanging out windows, people filming. You might have to say, look, parents, I need you to be on board with what we need to do. We need to go out of this ambulance now. We need to do a number of procedures that are going to be quite exacting, quote unquote, in brackets, in commas, risky, like an anesthetic. And we may have to do other procedures as a result of that because they might have other injuries. And so actually, can you work with us so we can deliver the best for your son, for your daughter? We need you to help us. We need you to be on board. And then you can do other things like getting bystanders to hold blankets up to create some confidentiality space. These are things easily said, much harder to do in practice. But the points, I suspect, and I suppose, center around this idea that we call it SCIWRA, or spinal cord injury without radiological abnormality. These are the pediatrics that we're worried about, and we must have a high level index of suspicion for, and we're going to do the very best that we can with regard to spinal restriction, spinal immobilization principles. We just might have to go about things slightly differently, getting people on board. Maybe, if an individual, a parent, let's say, responds better to a female colleague, or maybe initially doesn't respond to that female colleague, but responds better to another male colleague, then you're going to work around, delegate that if you're the caregiver, to then work with these patients. But essentially, it's on the SCIWRA principle, and we can share some evidence base around that, or some nice sort of mnemonics and slides that work well to get your head around that.
So Jim, my next question really would be around, it's fascinating to talk to you actually, because you've got a foot in two camps from two very much part of two different high performing teams, but you also do a lot of extreme medicine and medicine in remote places. My next question really was around how technology is changing pre-hospital care around spinal trauma. And I guess my inference is around MDT, some multidisciplinary team approach from reach back, but also the adage of AI within being able, in remote places, being able to, so in certain places, be able to read CT scans from an AI imaging to give you almost a real-time interpretation of what's been seen in a remote location so that you can better make a triage decision. But to either one of those points, could I get you to speak to just how it's bringing professionals together to enable better decisions at point of wounding?
Yeah, and you know what? We sort of have a limit on our imagination, and it's fascinating because, looking into this, there's some genuine excitement around what is being done and what can be done, and maybe what's on the horizon. And so some of that is around wearable technology. So, it might be Google glasses that you're then able to transmit that information, across the globe to experts and specialists, which then guide you to make better decisions. That's really easy now. And we have technologies like Skylink that really, if you're a medic in Antarctica, before, there was real limitation with technology and network and systems, some of this technology that is very much available, very usable, and is being used, Whether you're a high net worth individual needing this medical cover, or you're a system like the British Antarctic Survey Team, where you're looking for much more dependable systems to give you better sensitivity and an improved specificity to manage these patients and just reduce the risk. So I think that's really exciting. I think virtual reality is really absolutely being a game changer around particularly training and how you can prepare medics and teams. There's some really amazing interactive stuff, and with sort of immersive virtual reality. I think probably in the next 10, 20 years, we're going to be seeing more around handheld imaging and scanners. We were only the other day talking about there is technology being tested and tried right now around a piece of equipment that can place a femoral arterial line. You put this on a patient, it does the rest. This is stuff that knows no bounds, and it's our imagination that is the limiting factor. Smartwatches, technology within vehicles that record, high energy impacts that can then give you real information to give you a linear piece of information around the risk. We already see that with diabetes. So if I'm going to a patient that might be potentially hypoglycemic, I can literally just look at their phone, look at their smartwatch, and just see how they've been trending over that day. It really is changing the game. And then I think lastly, maybe, and this is an old interest, is around biomarkers. Taking blood samples is a relatively easy thing to do. And for spinal cord injury, cell-free DNA or protein markers are certainly exciting territory around showing that these patients might have a spinal cord injury, and therefore we're going to treat them accordingly. So the future is bright, and I think it's around the corner sooner than you might think.
Listen, that's fantastic, actually, and like you say, real evolution in practice, and two heads are better than one, and just solving problems with different perspectives is absolutely where it's going to be. Jim, it's fantastic just to chat to you, really, and just to get your perspectives, to get your guidance on how you approach spinal trauma, both from a post-op care perspective, but also from a remote medicine perspective, because I think the lack of diagnostics in remote areas, it proves super challenging. I guess my final question, really, as we come into land on the interview, really would be around if you could just speak to some take-home messages. I know even last week you were teaching for World Extreme Medicine about the salience of how you approach trauma in the mountains, but could I get you to speak to some take-home messages and front of mind messages for those listening?
Yeah, and some of this is tried and tested or old adages. I think the first one, and I genuinely believe it applies to my frontline job as well as austere medicine. That is that we should think about bothies before bandages. So think about that environment before the care. That might be simply, my two young adults on an electric scooter in a chaotic scene. Let's step back. Let's see what's going on. I can make a better assessment and get more information. Let's make this a safer environment. Let's get, what we need to do to make this a better or safer environment. And then I can proceed with that assessment. Then I can proceed with that management and care. So that, I think, would be my first point. The second point, I think, is around essentially management and triage. So a lot of this boils down to what you can do at the end of the day. So if you're in Antarctica and you're waiting for a med flight out, you might be genuinely limited to what you can do and how long you will have to wait until either a weather window or that medi flight is able to come in and land. And so you're going to do the best that you can. And I think that becomes quite simple and quite obvious to do in front of you. The other thing is around triage, and so that that might be whether you're on a frontline professional role or in an austere environment, and that is sort of trying to sort of think 3-4 steps ahead, and this comes back to that principle of do an exquisite primary survey where you can do a detailed secondary survey, because it might be that you're worried that they have got a spinal cord injury and some other concerns, and so that might change where you triage. So it might be that I don't know, you're not going to go to Argentina, you're going to go to South Africa from where you are. It might be on a frontline role, we're going to go to a major trauma centre because I'm concerned they're going to need multifaceted specialist involvement. I think they're the take-homes for me. The rest is easy to pick up on, reading up on things like the Faculty of Pre-Hospital Care guidelines, NICE guidelines, Canadian C-spine rules, and there's some great courses. Whether it's something like ATAC, which is high fidelity simulation that really puts you into a stress situation while trying to deliver very high top end medical care, or it's an acronym course that you can do and that really gives you building blocks. It depends where you are on your career. So I think there's some of the thoughts that seem to be omnipresent in my head.
No, absolutely, absolutely, and it's fantastic actually. And to your first and most seminal point about winning the environment before you win the patient. So win the environment, keep the patient warm, and mitigate. And this absolutely applies to pre-hospital care, because in the UK, US, and globally, because patients often on the floor, multi-system trauma patients, get cold super quickly, and we all know that hypothermia is one of the lethal triad indicators, and it's one of these things we really need to be mindful of, and it's one of the predispositions that can really come up when you are immobilizing someone. They get cold extremely quickly through conduction. So it's winning the environment, keeping the patient warm, and I think that is, you're right, that alone is an excellent principle too.
It has brought me to one thought, is that if you get an opportunity, be a live patient on some training, go through some of these processes and principles that we put people through when we're delivering management and care. Holding a patient's hand, someone who knows that they've probably broken their neck, have a spinal cord injury, they know, and they're really scared. And actually, dedicating someone to be by their side and just saying, everything's going to be okay. We're going to look after you. We're going to not allow anything worse to happen. Really thinking about that environment for them, like patients getting cold quickly. These things happen. So yeah, really valid points.
Jim, listen, thank you. Thank you for the last hour, and thank you for your perspectives.
Thank you, buddy. It's lovely to catch up with you, and let's see what we can do the next time.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.